Thank you. Thanks so much to the SAGES Program Committee and the session moderators, Dr. Kripp, Santos. It's truly an honor and a privilege to be here today with you all in person in Vegas. It's been more than a year since I've been to a scientific surgical meeting, and so super pumped up. We've heard quite a bit so far about some of the nuts and bolts and some of the technical aspects of performing transcystic lap CBDE, and in Fernando's case, the crazy choledochal route. At some points, I was like, are we watching Armageddon? There's like an asteroid there. You're shooting it with like missiles and lasers and suturing, and I'm pretty sure that wasn't like elapsed time. That was like real time. Yeah, I could never do that. I have no relevant financial disclosures, and in terms of the next 15 minutes, what we're going to do is a couple of things. One, I want to give you a little bit of a background as to why I started doing lap CBDE and why we've introduced this technique at my academic institute. And then the remainder of the talk is going to focus on, again, some of the nuts and bolts of how do you actually successfully launch a program or a service line whereby you're performing this on a fairly routine basis. How are you going to get buy-in from the folks in the OR, from admin, to invest in your equipment and supplies? And so we'll talk about how you get off on the right foot. And then in the title, which I didn't choose, there was something about the evolving role of technology, so I'll say like 5 or 6 words and a slide on that. So in terms of where I practice, I'm at a level 1 trauma center in South Los Angeles. We do trauma as well as acute care surgery, and we do both. We see over 4,000 traumas a year. We do all of the EGS that comes through, and I have 7 full-time partners. And if you've seen me ever talk about this, I like to refer to ourselves as a gallbladder center of excellence, and I'm sure many of you in the audience can relate, because in fact, if we're not doing appies or bowel obstructions in the middle of the night, we're doing choles during the day and well into the evening, and that's where a lot of our research is also focused. So when I got started with this, the main reason I got interested in lap CBDE was back in 2017 to 18, we took a little retrospective look at our experience with patients coming in with biliary tract disease for acute causes, not elective outpatient stuff. And what we found over about an 18-month period is that we had about 800 patients come in, and of that 800 patients, about 35 or a third of them actually had some complication of their biliary tract disease in the form of either choledochal or GB pancreatitis. Amazingly, when we looked at the number of patients that got either a pre or post-operative ERCP, it was about 50% of them. And so, as we've already alluded to, you're going to be doing lap choles, maybe you don't have preoperative imaging, or you don't have a suspicion for a CBD stone, you do your IOC, lo and behold, there's a stone. If you can't manage that right there and then, well, then your patient's going to have to wait around. When GI has an opening in their schedule, they're going to go for an ERCP. Hopefully that's the day after the lap chole. Oftentimes it's not, especially if it's a Thursday or a Friday, Saturday or a Sunday. And so this is what really got our group interested in the whole idea of doing transcystic lap CBDE. Fast forward, and again, when you look at the numbers here over the same time period from January to this past June, despite the COVID pandemic, we didn't see a huge decrease in the incidence of patients presenting to our county facility with biliary tract disease. But what we did notice was that the number of patients requiring either pre or post ERCP decreased by an absolute of about 15%, which is pretty significant. So again, I think if you're thinking about starting or launching a successful lap CBDE program, the first question that should come to mind are, what are the potential challenges? What should I be anticipating? What are going to be the roadblocks? And I've broken it down here into a few different areas. Number one is training and education and personnel. And I think these two go hand in hand, and you want to really attack these at the same time. And then there's the issue of capital, equipment, and supplies, as well as workflow and restocking, and we'll touch upon that in just a bit. So again, you want to get off on the right foot, and so I'm going to share with you my top 5 hacks to ensure early success of your LCBDE program. And hack number 1 is the more the merrier. And I bring this up for a couple of reasons. One, when I got into this, it was sort of just myself out of a group of 8, and I really kind of, in retrospect, regret that. It would have been better if at least 3 or 4 of us kind of participated in some of the early education and training, because when it's just 1 out of 8, I'm only on call 1 out of 8 days, and so it's difficult sometimes to get our patients to the OR who might be candidates and do this successfully. When it comes to the more the merrier, again, outside of faculty, you gotta get buy-in from the OR staff, especially the nurses who are gonna be helping you, as well as the scrub techs, to set up and the workflow. And I think the key here, and I'll talk about in just a minute, is really to keep things focused on your patients and outcomes. And then again, the residents. I can tell you that as we've done more and more of these through the years, the residents love this procedure. I mean, the first time you actually stick a choledocoscope into the actual CBD and you're looking around and there's stones in there and you're using teamwork to fish that thing out, it's super exciting. Everyone gets really enthusiastic. And so you really want to make sure the right personnel are on board. When it comes to the OR staff and surgery colleagues, I think this is another important thing. So I'm an acute care surgeon, and I have other folks in my department who don't like the idea of me starting to stick wires and cameras into the CBD for fear that maybe you're gonna bang the CBD. And we've always been trained, at least in the last 10, 20 years, is don't touch and stay away from the CBD. But we know that this is a safe procedure and that the complications such as CBD injury or a cystic duct stump leak are pretty low. And then depending on where you practice, so I'm at a county facility, we don't bill. I'm paid on an hourly basis. I show up, I do my work, I go home. But if you're in a private setting and you're now potentially taking away business from your GI colleagues, well, this might become an issue. And so even though we're not billing, we were very certain very early on to involve our GI colleagues in the process. And we adapted this from the ASGE guidelines for whom shouldn't undergo an actual lap CBDE or some form of CBD interrogation. And when you get that sort of collective collaboration, then that's when you can start to really work together without stepping on each other's toes. And hack number 2, again, is to focus on your patients. And this is what the message should be when you go to your administrators for capital funding or when you're talking with the OR staff. We know that lap CBDE patients are gonna stay in hospital for a day or 2 less. And in this day and age, when we've got a pandemic and a 4th or 5th surge, the more beds we have in hospital available, the better. So the shorter length of stay, the better the outcomes. They're not hanging around other people and getting potentially infected, and you're saving costs. Hack number 3 is start small, but just get started. So again, when you're thinking about launching this service line, I don't know about you personally, I don't do gallbladders unless I absolutely have to after 11 or even 9 p.m. But just think about starting this with maybe an elective case or as the first case of the day in the EGS ACS room, and just focus in on the day shift. So you have a smaller group of people who are gonna start to become exposed to this particular procedure. And by now, we've been doing this for about 3 years. Now our evening crew has been trained up, and they're very comfortable starting and ensuring that everything moves along smoothly. Sorry, this big green arrow came onto the screen, it kind of freaked me out. Hack number 4 is prepare and also stay organized. And I think we already heard a little bit about this. So there's the easy way, and this is our OR, our ACS EGS OR, and we've got all of our lap CBD equipment stocked there. And then there's the hard way where you can try to put your stuff together, and this is how we did it very early on before we could convince people that this was a good idea. We would go to the urology OR, we'd go to the vascular suite, we'd go to IR and kind of just jury-rig this set, but you don't have to do that in this day and age. And again, if you look at Dr. Santos, he's like really got it down. This guy is prepared, he's organized, he's good to go. And then have a dedicated tower. So this lives just outside of our OR. If we have a case where we're doing a lap chole and they always get consented for IOC, possible exploration, blah, 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 and you have a high index or even a moderate index of suspicion that your patient is gonna have their CBD interrogated, have the equipment in the room, and then make sure you have your OR flow and setup ready to go. So you wanna set up the same way, the same time, every single time you do this, you want to do it the same way, all right? So the monitor typically lives on the left side of the patient, and just make sure that your OR staff are familiar with the setup. I have to put out a little line about the technology. Again, when you saw that the actual setup, we use the Cook LCBDE kit. It's sort of a one-stop shop for everything you would need minus your cholecystoscope. When it comes to the actual technology regarding cholecystoscopes, there's now disposable scopes that use the spyglass technology. And outside of just the actual equipment that we're using and the supplies, I think it's so important for us to think about how we're educating the next generation of surgeons. And so when I first took this course back in 2018 at Cedars, we were using very rudimentary lap box trainers. And it was literally, I mean, you came up with this, like a Penrose drain in like a lap box. But the technology has improved significantly. And so the ability to kind of integrate some of the radiology together with the haptics as well as the actual performance of this procedure. And now we have sort of validated assessments to measure your ability to perform this procedure successfully, as well as courses out there for you to attend and practice. And so there's certainly a role for evolving technology, both from a clinical as well as an educational standpoint. Hack number 5 is measure your progress. We've been doing this since 2018. We presented the results of our single institutional study last year at the AAST meeting. We had about 75 patients, and it's really interesting to see that the duration of this procedure or operation really starts to diminish or decrease significantly over time. I'll tell you that the first probably handful, 5 to 10, we were in the OR sometimes for absolutely ridiculous amounts of time, 2.5, even upwards of 3 hours. That does not happen anymore. We're almost on our 100th lap CBDE. And I can tell you that we've just fine-tuned it, and it's all about practice. And we can do these in under an hour. So it's really not that much added to your original procedure, and certainly beats having to stick around the hospital, potentially get another general anesthetic, and then undergo an ERCP with its attendant consequences and potential complications. So honestly, I think we should be thinking about this. It's not really a new skill set. This has been around for decades. There are systematic reviews, meta-analyses from multiple organizations showing that this is an easily acquired skill set and is safe. I think from a continuing professional development standpoint, it's worthwhile. There are also research opportunities, and like I alluded to earlier, this is really just a lot of fun. So in summary, 5 hacks. Again, the more the merrier. Make sure that you focus on your patient. Start small. Be prepared to stay organized. And make sure to measure your progress. Thank you very much.